Disease and care management is something that is necessary in the European countries and according to our healthcare systems. That's not something that only in Italy has to be implemented, but in all countries, because of aging population and increase of chronic diseases. And it is a need both to improve health in individuals, to have a better results in quality of healthcare provided, and also to create an environment where it's sustainable to have a better healthcare from a point of view of the economic system.
So we're at the conference this week to bring together, I guess, the results from 3 bits of work that have been done across Europe. So ourselves in the UK, colleagues in Finland and colleagues in Italy, who we all, within Pfizer, took a model for self-care and self-support for long-term conditions that had been developed by colleagues in the US. And over the last few years, we've been adapting that to use in European markets. So each of the countries has taken a slightly different approach based on their local circumstances. I guess particularly looking at their local policy requirements, how their local health services work, and we've adapted that model that works in the US into our different country settings. So each of us done it a slightly different way, and I guess partly why we're here at the conference this week is the opportunity to bring the results of those 3 different bits of work together, to talk about the similarities of what we've done, but also talk about the ways in which we've adapted that to the needs of the different markets.
We piloted in 3 areas, so one in the south of Italy, one in Rome, and one in an area at the center-east of the country. And the Ministry of Health and regional health authorities participated in this pilot, and the results we obtained in the pilot program were amazing, because from one side we could see some clinical outcomes and better treated patients to target according to clinical guidelines on one side. We increased patient satisfaction and GP satisfaction in order to engage people in a better teamwork around the patients. And also we could demonstrate that it is cost effective.
So in the UK, the way that we took this forward is in a slightly different way to the colleagues in the other countries, in that we've taken it forward very much as a commercial model. So it's one that we've been a commercial provider to the National Health Service for these kinds of services. So we've provided services now for nearly 10,000 people across the UK. We've worked very much in partnership with primary care trusts, and they've been our main contractors, our main commissioners so far, what we do is very much work with them to address the programme to the particular needs of their local populations. So if you take that, our main piece of work that we're talking about here, which has been in the city of Birmingham, there we've had some very interesting requirements of a population that's very mixed in terms of its the ethnic mix, the social demographics of that population, and we try particularly to tailor that piece of work to help those who are in the more deprived communities of Birmingham and who have more issues to do with inequalities of access to care. So we've worked very closely with colleagues in the primary care trust to do that, and we've actually delivered it with and through other NHS providers, which is somewhat of an unusual model for a commercial company to take forward. But it's been a different departure for Pfizer in the UK to take this kind of work and to actually have essentially a different business that works independently of what happens with medicines.
In terms of health outcomes, we saw that the number of patients that were cared in the pilot program who reached the target for diabetes, hypertension, lipid, and general cardiovascular risk factor were highly significantly higher than the control group. And that means that really in from 12 to 18 months time, you could really improve the healthcare outcomes in such a short time. It's a short time for a chronic disease, of course.
Yeah, I mean, what we've been trying to do across the time that we've been running the programs is to develop a whole range of different outcome measures that represent the things that our commissioners and our payers think are important, the things that our patients think are important, and the things that our clinicians think are important. And you know, what we found across, it's been interesting the feedback we've got across the whole time that we've been running this service, that from a patient and a member perspective, it's very popular. They do enjoy and value the one-to-one contact with a care manager, and to have that ongoing contact with someone that they develop a relationship with. How that's then translated is that we've seen very positive results in terms of changes in their clinical metrics as a result of some of the behaviour changes that we've been able to support them with. So we're consistently seeing improvements in some, if you take cardiovascular medicine, for example, in things like blood pressure, in their cholesterol levels. We've had good success with our diabetes patients in terms of reducing their HbA1cs. So we've been able to show those benefits to the clinicians that I think is important for them. And then we've had some good information around our impact for the commissioners, because obviously one of the things they're particularly interested in is what role can self-care and self-management play in reducing the use of unscheduled care by people with long-term conditions. And the Department of Health in the UK recently produced a report looking at some of the work that we've done in Birmingham. It referenced it, and you know, the estimation is, particularly to take one year around COPD, that we could have saved as much as £30 million in avoidable hospital admissions through the work that we've done with our COPD patients.